Welcome to another episode of the Face Podcast. Today, I'm interviewing Dr. Jonathan Sykes, a facial plastic surgeon with over 35 years experience. He is known for his signature rhinoplasty procedures and his interest in masculinization surgery. We welcome today Dr. Jonathan Sykes. I feel like I'm talking to an old friend.
Old is the operative word.
You know, you look nice. Great. Dr. Jonathan Sykes, it's so lovely to see you again. Thank you for joining me on the Face Podcast today.
Thank you for having me, Alex. It's great to be here.
You are a board-certified facial plastic surgeon.
I am.
You have 35 years experience. I want to talk about how plastic surgery has changed and evolved, even, more recently in the last sort of five to 10 years.
Mm-hmm. Well, the media, including social media, but has made plastic surgery a little more accepted everywhere. And that's brought out more surgeons and more people that want to do this, more injectors. There are injectors everywhere now. Mm-hmm. People that went to residency to become emergency room doctors or to become anesthesiologists are doing not necessarily surgery, although sometimes they actually even are doing surgery, but they're injecting and they're expanding that and doing lasers and doing many of these things. So the field has really changed. How I think that's changed for patients, it's made things very acceptable. Mm-hmm. It's made it very accessible. So you can almost go to your corner and find an injector and find a whole med spa that is doing that. And that's brought with it a cadre of other things, which would mean that people are changing the way they advertise for this. They're changing the way they get patients. Patients are changing the way they get information. There's an information glut, which is really supposed to be education, but it's guised as education, but it's really marketing. Mm-hmm. All these social media things are marketing to patients. And so it's really changed the whole game of what patients are looking for and what doctors are doing to get those patients. It's really a big change.
I mean, really misleading too, in terms of, a clinician can have a very, very large following, but not really deliver really good results.
Right. I mean, they can be associated. They don't have to be associated in any way. The amount of followers and the quality of work, really, that's what we would love, to think that if you're followed a lot, you've got great quality of work. But what I've found that's happened is there's a lot of deception in what people are doing. And I don't mean to be all negative about this, because I've loved my job for many, many years. I'm still doing it despite not really needing to financially. I still love doing it every day. I did 2 facelifts today, and it got me charged up in the morning, and it still does for me. But I think there's a lot of deception. There's this pressure to get results out early, to show that you're doing a lot of things that you're doing, and then maybe to artificially show your results. Maybe there's some Photoshop.
Sure.
If there's not something as flagrant and as deceitful as Photoshop, there are people that are lighting things differently, positioning the patient. I call it the photographic facelift. This is the before, this is the after. And people do little parts of that, or the person is above, they're photographing you from above them, and it makes, you don't see their neck issues as much. So all this goes on. And I don't mean to say that there's all bad stuff going on, but there's a lot of pressure for young surgeons to get busy immediately. The old model was we didn't have as much communication, as much information, and we couldn't get busy when we were 31. It just didn't happen.
Well, it took a long time.
Yeah, it took a long time. And the practice building then was really, it was organic and it was there.
And word of mouth.
What's that?
And word of mouth.
And word of mouth.
Yes.
Exactly. It was, and that's still, it's interesting. I practice in 2 cities, and in one of them, I've been there a long time, and I feel like the patients just keep flowing to me there. If it's not somebody that I did their daughter or their mother or something like that, it's a patient of mine that I operated on 15 years ago. I did a facelift when they were, 48, and now they're 63 or 65, and they're deciding to do something. So on the other hand, we're here in my office in Beverly Hills right now, and it's a little different here because advertising is the word here. It's not as much of the organic stuff. Even the people that have been here for very long periods of time, they feel compelled to advertise and to do social media a lot, or else young people will advertise them, outwork them.
Mm-hmm.
And
so for the consumer, this, as you said, this overload of information online, on TikTok, on Instagram, on Facebook, on websites, they're watching even, influencers, celebrities now being much more transparent about the procedures that they're having. Has that helped your business grow?
I think it helps it and it hurts it. It helps it in the way that if it happens to me, it helps a little bit. But if it happens to 3 people next to me, it helps them. And they're still the surgeon that they are, and I'm still the surgeon that I am. And it can artificially inflate, and it can do both. I think I really think that does happen. So
you're very well known for your rhinoplasty, and that's a decision, a very personal decision that patients make. Talk us through that. Talk us about some patients that you've come across over the years.
Yeah. Well, I will say this. I used to do a tremendous number of rhinoplasties, and now I do a little less. And I think that's a social media and media driven thing too, because I think people are, when they look in the mirror and they see a little of this, they don't like that at all. And so it's turned more into the aging face, the rejuvenative stuff. And I still do a lot of rhinoplasties. I think the nose is the thing in the center of the face that can make all the other features look better. So we can take somebody that's unattractive and make them attractive. It can take somebody that's really attractive and make them stunning, and in both women and men. And so, and balance is the key. I get people that want overdone looking noses, and that's a social media thing too. And some of that is because they look at themselves with their close-up pictures that they've taken. And if you think most iPhones or other kind of smartphones have these wide-angle lenses and from close-up make our noses look wider. So people want narrow, tiny noses. I generally like balanced noses that balance the other features, strong features, something like your nose. It looks great. It's balanced on your face. And so I like that. I don't like something that screams, I've had an operation. I don't like that when I see that.
Do you think that the increase in use of filters, I mean, we're all guilty of using them. So the filters often make the nose smaller and thinner. So people are seeing themselves or preferring to see themselves like that. Has that been an issue for you in consultation?
I think people are commonly now showing me what they want. They used to bring in a few pictures
of Johnny Depp.
Yeah, 15 years ago, 20 years ago. Now they've got 40 pictures on their phone, and we scroll through them, and some of them they can have. And some of them they can't have. And they can't have it because of some physical features of their nose. And what happens is some surgeons cower to that. They overdo the nose. It looks too turned up. The bridge is too taken down, and specifically just when it gets to the people that are tough to get that on are people that don't have thin or moderate skin thickness, but they've got really thick skin thickness and they want a tiny nose. And that's very hard to do in thick-skinned noses. And that's a specific thing that every rhinoplasty surgeon knows about.
There's been a lot of talk about the increase in rhinoplasty in Turkey, for example, and the results seem to be more extreme. Is that look outdated?
Well, there's an interesting thing. I think of all the countries I know, and interestingly, I'm going to speak in Istanbul in about a week and a half, but of all the countries I know, for whatever reason, the dishonesty and the need to outcompete your peer or your competitor is strong there.
Oh.
I mean, to me, I'm fine with competing, but I would never want to do that and be dishonest to the world. That's just the way I am as a person. But I don't really see that, and I've seen what often happens if a nose is overdone or over-reduced is the nose looks very good in the beginning when the skin thickness is there a little more. The swelling has not gone away, so the swelling is slightly masking. So it's an over-reduced structure and the skin. But then as the wound contracts over 6 months, 12 months, 18 months.
Takes a long time.
We have a nose that looks over-saddled, over-turned up with some malpositions and it looks operated upon. Small noses by themselves are not bad. They're good. But sometimes in order to make the nose really small, you have to do some things to it that may not look good over long periods of time. And I think when people travel to Turkey, they don't get told that. And so I've had several patients of mine that or they've come to me, maybe they weren't patients of mine, but now they are, and they've gone to Turkey and had their nose done. And they're happy in the beginning, and then they're not as happy 6 months later, 8 months later. And I'm not saying that the surgeons in Turkey are bad. There's some very good surgeons there, but there is a real pressure there.
Okay.
Like there is in Los Angeles.
Yeah, sure.
To outcompete.
Sure.
And to maybe to do something that's not quite, that's not quite, doesn't stand the test of time and doesn't look as natural. And I have patients now tell me, I don't want natural. I want it to look like it's been done. It's sort of a funny thing and sometimes I have to tell them, maybe I'm not the surgeon for you.
Which is very responsible.
Yeah.
So. Absolutely. Even in the non-surgical setting, turning people away is definitely a good idea.
Right. Well, I'll tell you one thing that's interesting about noses when you say the non-surgical setting. So I also do a lot of injection rhinoplasties where we're injecting the nose, building up the bridge, projecting out the tip. Almost all of those patients are happy. And if you think about it, we're making their nose a little bigger, but it looks balanced. But they don't get to try on all these things. But with injection rhinoplasty, we're actually augmenting the bridge of their nose. We might be camouflaging a bump. The bump's here. We're camouflaging above and below it to make it look straight. So, but the nose is actually bigger, but they like it because it's balanced on their face. And it's rare that I get somebody that does not like an injection rhinoplasty. An injection, I won't call it a rhinoplasty, but an injection nasal procedure that I do. They really love that. They love the immediacy of it. They love the ease of it.
A really good understanding of the anatomy, though, is very important.
Yeah.
And also whether they have had a previous rhinoplasty.
Absolutely. Because there are some devastating complications that can occur with injection rhinoplasties. So in people that don't understand the anatomy, and the problem is anybody can get this syringe, almost anyone, and they can quickly inject noses. So they almost don't know what they don't know. They don't know what they don't know.
I want to talk about a patient has been with you for a few years, late 30s, early 40s, maybe even mid 40s, looking like they have had, neurotoxins and some fillers over the years. You are a facial plastic surgeon. They start complaining that, the jowl formation is creeping up on them and they're starting to talk to you about it. At what age do you start discussing facelifts? Well,
it's really when they discuss what bothers them to me. So if they have something here that bothers them and I don't think I can correct it with injections, I tell them. Or once in a while, they'll say to me, it's just not working as much for me, or I'm needing too many syringes, any of the above. So it's more that they come to me. I listen to what they say to me. They seek me out because that's what I do. And there's no question that a well-done facelift is the best aesthetic procedure on the face. It's the best thing on the face. It makes the neck look better. It makes the jawline look better. And the bigger thing that it makes, and as I'm staring at your very attractive face, I see that it's relatively top heavy, which is how faces are in youth. But as they age, they get a little more bottom heavy. So they lose a little bit of their volume up here and they gain a little bit down here. So what happens with an injector, they can't change that ratio per se, but they add up here, which is a camouflaging agent, or they add a little bit down here to make the jawline a little stronger. Well, that works for a while, and then it doesn't work so well.
It works for a while, but it also adds width to the face, which can make them look more masculine,
absolutely,
correct?
Absolutely. And I think it is sort of a weird thing that happens with anything that we do, but we tend to diagnose things based on what we do. And that might sound weird to somebody that's listening to this, but really what I'm saying is if somebody has a droopy eyelid and they go to someone that can surgically correct that, they diagnose a lot of droopy eyelids or ptosis of the eyelid. If somebody can't correct that and they have nothing in their, they tend to not correct it as much. Maybe they correct it if it's really bad, or they diagnose it if it's really bad, but they don't diagnose it as much. They diagnose the things that they do. And that nothing is more true of that than with injectors. Injectors tend to think that everybody is missing volume.
Absolutely.
Right? Everybody in the world is missing volume because they have volume. So, and some people are missing volume.
Sure.
You know, you look at my face, it's, you know, I've recently lost about 10 or 12 pounds on tirzepatide. I did that purposely. And
are you feeling better?
My body feels much better. I think my face looks a little older.
No, I don't. I think you look great.
Yeah. Well, it feels that way to me. I mean, you know, that it's, so maybe I'm the person that seeks volume now. I've had it a couple of times in my life, but maybe I do that. And so really in answer to the long answer to your question, when is the right time? I don't think there is an exact right time.
Okay.
I mean, sometimes people come to me and they get their first facelift when they're 67 and that's their right time. You know, and sometimes they're 38 years old and they're saying, you know, I don't like the way I look and I've tried fillers. It's not for me, or it's not doing enough for me.
So that would be more for beautification.
Yeah, it's beautification.
Sure.
And it's not, I mean, all of this is beautification. Even terrible wrinkles and terrible sagging, it's beautification. That's how we age. And we're just looking at the best ways to turn it around. That's what I've been doing the last, you know, several centuries, or the several decades of my life, rather, you know.
They say that eyes are the window to the soul, and blepharoplasty is a very common plastic surgery procedure. Can you talk us through that and, you know, educate our listeners on what is a blepharoplasty and the difference between the upper and the lower lid?
Right. So the term blepharoplasty means formed, that's the plastic part, formed eyelid. And so, you know, it's sort of a euphemism for what surgeons do to this. Blepharoplasty involves removal of skin and or removal of fat and or change in the position of the eyelid. So to me, every eyelid should have a really careful diagnosis as to what's going on. Is it extra skin? That's common as we age a little bit. But some of those people have superimposed on that actually ptosis of the eyelid. The lid itself is droopy. Some people will get a lot of skin in their upper eyelid and their lid never droops. It just is heavy. And so you take the skin off, they look good. Now, in some subset of those people, that'll also be associated with brow drooping.
Sure.
So we want to lift the brows. And so I diagnose the person as to, will eyelid surgery alone work, or do they need brow lift and eyelid surgery? And in a similar way, I look at the lower eyelid. And now more commonly, that could be a little extra skin. But it commonly, if you look at my eyelids, Alex, I have bulgy lower eyelids, which is just what my father had. My father, as you know, was really close to me. He passed away a couple of years ago when he was 99.
He had such a lovely face.
And when he was 71, I did his lower eyelids. And he had big bulges of fat in his lower eyelids like I do. You're like your dad. If I could be totally like my dad. That would be great. All his values and all the good things about him. But so sometimes we just either take the fat out or transpose it. We take some of the bulge out and we add to the concavity below. We take away some of the convexity and we add a little to the concavity to make it smooth.
Can you sew some of the fat down?
We can.
Okay.
And we create a little pedicle in the fat and we sew it down a little bit onto the cheekbone or the periosteum that we transpose that fat. We reposition it.
Because if you took all the fat away, the patient would look very hollow.
Particularly over lots of years.
Yeah, sure.
And it depends on you could probably take a lot of my fat away and I'd be fine with that. And then the other thing with that is sometimes there's extra skin. And what often gets done with lower eyelids is in an effort to get rid of wrinkles, we take out too much skin and the lid pulls down a little bit, which is not acceptable in lower eyelid surgery. So often we've got to do secondary things to correct an overdone lower eyelid. You've got to be the most careful with lower eyelids of anything on the face. We can pull the neck really tight and we're okay with that.
Sure.
We can pull this really tight if it's in the right orientation. If we pull it like this, no good. No bueno. If we pull it vertically, relatively vertically, we're good. So we can pull the face very tight. And if we pull a little tighter, there's no penalty to that. On the other hand, if we take a little too much skin out, we get secondary wound contraction and the lid pulls down. And that's not good. That looks operated upon. Sometimes I like to do 5 to 7 procedures on a patient at one time. And I like to tell them, I'd like it so that 3 or 4 weeks after the surgery, nobody knows that you had surgery.
Sure.
You just look good. And people tell me that all the time. I saw my sister, I hadn't seen her in 6 months. And she said, what did you do? Did you change your hair? It's my sister.
That's the best compliment.
Yeah, it's the best compliment. We don't want to make the face look done. In body plastic surgery, often people want things that look done. They get them overdone.
Sure.
Nobody wants the face to be overdone. We don't want to turn up the tip of the nose too much. We don't want to make the lips too big. Then people just stare at your lips. So the whole idea with eyelids is I call it the window shades to the window. We're just we're cleaning them up a little and making them look a little cleaner. That may be a little brow lift. It may be a little skin removal. It may be a little fat removal in the lower eyelids or fat removal and transposition. And sometimes I tighten the lid a little bit because that makes it look better and younger. If you look at your very young looking lower eyelids, I tell people that the lower eyelid cheek junction should be very high. If you look at me, my lower eyelid cheek junction is down on my cheek, and that ages me a little bit. If you look at your eyelids, it looks like your cheek is up on your eyelid. In fact, people like yourself, I come in and I say, do you have any issues with your lower eyelids? What do you mean my lower eyelids? What are the lower eyelids? They don't exactly know what that is. You and I know what that is, but they don't really know. I like to make in very young people or people that look like models like you, the lower eyelid is very short because the cheek is up on it. The cheek is up on the lower eyelid and the junction is very high. So that makes for a very aesthetic looking.
So you mean at the zygomatic eminence?
Yeah, exactly. The cheek is higher and the lid has no bulges to it. Okay. We can even get away with some wrinkling if we've got the stuff in the right position.
Sure.
I think there are people that are 65 years old with wrinkles because they've got beautiful bone structure and they look gorgeous.
Can we talk about, though, the misconception that the consumer believes that the lower lid area can be treated with a filler? What would be the percentage of patients that are suitable for that procedure?
I think in the early aspects of a little bit of fat bulge, tiny amounts of fat bulge and tiny amounts of concavity, so a little bit of bulge, a little bit of convexity, and a little bit of concavity below that, that's a good person to treat. But what happens in the people that have my kind of eyelids, you've got to overfill the concavity. We're always going to fill the concavities. And as you know better than I do, that's a lead to having complications in lower eyelid fillers.
Well, it draws so much water to the area.
It draws water. It gets edema. It looks lumpy bumpy.
It doesn't look good.
Because the skin is very thin.
Sure.
So you want to be able to treat that with very minimal amounts. You want to treat those infraorbital hollows with very small amounts. And if it's not treatable with small amounts, they probably would do better with surgery. Talking
about the lower lid area, I see a lot of menopausal women and the lower lid has very much thinned. What would be some treatment options, lasers or needling in that area that you would suggest?
So if there is just skin redundancy, and the lid has a very good tone, in other words, we pull on it and has a good snapback, they're good to have lasers or chemical peel or maybe microneedling. It could be one or a few treatments because that'll treat the texture of the skin and the wrinkles and make it good. When they have the bulges, like my eyelids, that doesn't work as well. So toxin for the dynamic wrinkles for these and lasers or peels work well if there isn't bulginess. Now, if you've got the bulgy lids that I have, and if you notice, I'm not a particularly heavy guy, fat in the lower eyelids that bulges is not related to body weight. It's not related to body weight. When I started my little dieting, I don't diet now, but the tirzepatide thing, I weighed 198 pounds. I weigh 186 now. My dad, when I did his lower eyelids, when he was 71, which was 30 years ago, because he would be 101 now if he were alive. When I did his lower eyelids 30 years ago, he weighed 150 pounds. So he was not a heavy man. And he had big bulges of fat in his lower eyelids. Sure. So this fat is present in some people. It's really not if you have fat, is the fat forward in your eye. And so some people don't have that forward fat. And that to me, I think needs to be treated surgically.
Absolutely.
So there's a continuum. And then lastly, just with that, in the lower eyelid, some people have a lot of mid-face hollowing and they might need either fat grafting or lifting of the cheek and fat grafting with the lower lid procedure. So there, sometimes for this relatively small problem, I'm doing their lower lids, a mid-face lift, and fat grafting to correct that problem. But that's what corrects it the best. So you've got to make that diagnosis. Do they need volume? Do they need cheek elevation? Do they need just lower lid tightening? And what do you do with the fat?
If you did the cheek elevation, though, is that part of a facelift or is that a malar lift?
It can be its own,
okay,
or it can be part of a facelift where we're lifting here. So that almost leads a new discussion. Does the problem go down here and here? And if that happens, they might have come to me for lower eyelids and they end up getting lower eyelids and a lower face and neck lift.
There's been such an increase in our customer base with male patients, and you are well known for your male aesthetic prominence in your practice. What are the men asking for?
Well, the most common things they're asking for rhinoplasties. Men in general don't want things that need a lot of maintenance.
Sure.
If I told you needed something that needed maintenance, you'd say, yeah, sign me up for that. Most women would say that because they're used to that. They do their nails.
We love it.
You do your hair.
Yeah.
People color their hair. Men as a general rule, I'm in an advanced age. I don't color my hair. I color my beard once in a while, but I don't color my hair at all, which is nice. I'm not gray. But men don't love maintenance. We just generally don't love that. If you gave men the choice of they don't like the fact that their hair is thinning. We could inject you a bunch of times. You could wear a scalp thing. You could do it, or you get hair transplants. A lot of men say, how much does it cost? I'll do that scalp. I'll do the hair transplant.
Because it's a one-off.
It's a one-in.
Yes.
One and done. That's just psychologically men are a little different. And that's changing a little bit because more men are using skincare.
They are.
I don't use any skincare. I should, but I don't. It's just not what I do. It's not what I grew up doing. And if I talk to my esthetician in either office, they would kick me, but I don't use it. I just don't do that. And so men want, but if you told me, there's something that we could do to correct your neck and it's one and done. If you told me I'd have to do 8 procedures for this, I'm not in for that. You told
They're
me.
They're not interested.
Yeah. Take my lumps, pay some more money. I would be okay with that.
So they're asking for jawline enhancement or strengthening their chin.
Yeah. So there's more now acceptance because I think so many injectors of how strong jaws look good. And it's an interesting thing about jaws. I've written a lot of articles in the literature about chin surgery and jaw surgery, a lot of them, book chapters. And I did a little research, and it's interesting if you look sort of phylogenetically about how animals, no animals have chins, and no U.S. president has ever had a weak chin.
Interesting.
There have been a lot of presidents. So we like people that show up on camera and have a strong jawline. And this is one thing that we can do pretty nicely in things that otherwise look good with filler. We can do it with fat. We can do it with filler. In the front, we can do this with a chin implant. But back here, it's harder to put implants in and have the complications be low.
Sure.
I like doing chin implants on people a lot. I don't like doing more posterior implants. And it's not that they couldn't look good. It's that the complication rate is higher.
So would you use a combination of surgery and non-surgical technique?
Absolutely. Absolutely. And I do a lot of that with people. And I personally do a lot of transgender surgery. I like to call it gender-affirming surgery.
Sure. Male
to female more commonly, but some female to male. And people want stronger jawlines. So, and their chins, they want a little differently. Men want a squarer chin and women want a little more pointy a chin.
I really want to touch on this area because it's quite new to the plastic surgery world, which is masculinization surgery and treating the transgender patient. This is something that you're quite passionate about. So talk about your journey with your patients.
I mean, I'm a person who believes in tolerance of everything. And I want people to be happy in their skin, just as a general rule. And in general, people that want gender-affirming surgery, if you think about it, it's not like they want to be with someone else. They want to be someone else. They don't want to be with someone else. They want to be someone else. They're not happy in their skin. And I have several really dear transgender friends that, have told me their life's thing. I grew up and I wasn't happy. I was like sneaking out of the house and wearing clothes. And, so to me, I have always done a lot of bony surgery in my life, in addition to soft tissue surgery, some on the nose, but some on the jawline, on the forehead. So as an example, if you look at most guys' brow bone, it's fuller and thicker.
Yes.
So what I do to them is either take the brow bone off, drill it down, contour it, and then put it back on, replate it, or I just directly contour the bone. And sometimes I have to contour the bone way out here because they have a prominent rim and a deep set eye. And I did that to somebody this morning on one of my facelifts. She had a more masculine eye and a very deep set eye. And I did a little internal brow lift just through an eyelid incision and drilled down and contoured her bone. Almost like I would do in a transgender or gender affirming surgery, but I did that to her. And
how fascinating.
It opens up the eye. It makes the eye look less deep set if the bone overhangs. In just the opposite way, some people may want a stronger. Now that gets a little more tricky because is it an implant? Is it a customized implant? So it's all of those things. And in a similar way with the chin, I commonly, in most males that want to be female, which is the more common, I'm taking the chin and making it a little smaller and making it a little more pointy, a little more angled. And if I were to do that to a male, I might put an implant in that was a little squarer.
Yes.
So that's the way we change it. And in a similar way, most women have smaller noses than men. I mean, if you think about it, the average woman cranium is a third less in size than males, right? Obviously, there's some women that are 5 feet tall and some that are 5'10" like you, but we've got, but the average is smaller. So in noses, we might augment the nose in someone that wanted to be masculinized,
yes,
and reduce it in people that wanted to be feminized. But it's not quite as simple as that with the nose because there are other factors.
So there must be a lot of consultation in leading up to this kind of surgical procedure.
Yeah, the first thing is the thing that I teach everyone that's learning about aesthetic medicine. And that's one word, and it's listen. Because it's listen to what the person wants. It's listen to what they want. And sometimes you can't get them what they want. They want something but most of the time, you may massage what they want and you can do and get that real close to each other. And you can say, I can do this, this, and this. I may not get everything you want with that fourth thing. So I talk to them. And sometimes I talk to them about what I see. You know, the average male has a pretty prominent Adam's apple.
Yes.
I don't know if I have any whiskers on mine right now, but and that's because the average male's Adam's apple is sort of like that. And the female Adam's apple is more like that. That's the cartilage that sits in front of our larynx and protects our larynx. So in a lot of males that want to become females, I drill that down and make it softer. I make it have a softer angle. But sometimes people come to me and they didn't know that they were able to do that. And so I talk to them about all the things that I see. And they may say, I like 1, 2, and 3, but I don't like 4. We're not going to do that. You know, most of the time, it's very interesting about the people that come to me that want gender affirming surgery. They're more open to my suggestions than my average aesthetic patient is. The aesthetic patients sometimes come with their own idea. But these people have recognized in themselves, I'm not happy with who I'm. Maybe I ought to listen to somebody as to what they see.
Sure.
Now, at the end of the day, I tell them, you know, you didn't ask me for that. I want you to think about that and tell me if that's an okay thing for you. And that's a tactic I use for people, let's say, that are just coming to me for aesthetic things. Let's take an example. I see a 20-year-old woman who doesn't like her nose. She's got a bump in her nose and she wants me to shape her nose. And she has a very small chin. And she may have recognized that, but her nose is overwhelming to her because she's taking selfies. That's the overwhelming thing to her. And so for that person, I may say, would it be okay if I told you something that I saw in the aesthetics of your face? And I ask for permission. They usually give it. And I tell them, and I say to them, listen, you don't have to do this. This is what Jonathan Sykes' vision for your face is. But at the end of the day, it's what your vision is for your face, not what my vision is. And if you don't like that idea, don't do that. You know, don't do that. Some people leave my office and they think he wanted me to do my chin. That's never what I want them to hear.
Well, you asked permission.
Yeah.
I mean, you are an expert in your field and the patient is coming to you for your advice.
Well, you know, that's an interesting thing. I'm an expert in my field, but they're an expert in their face and what they want. And I tell them that. They say, well, I'm going to listen to you. And I say, that's not actually good enough because you're an expert in what you want. And you have to really sit for a procedure that I talked to you about that you didn't come in here asking me about. I want you to think about that a little more carefully. That's what I tell them. I don't know if they hear that.
One of the cases that really stood out to me on your social media was a male patient with a very weak chin and jawline, and you treated him with non-surgical treatments, and the result was absolutely phenomenal.
Yeah.
And you obviously changed his life.
Yeah. He loved that. And
yes.
Yeah. Yeah.
It's remarkable what can be done.
Yeah. Yeah. If you look at what that is, and that individual not only had a weak chin, but he had a weak posterior angle, which this is a hallmark of a male, and he also had asymmetry. So I made him more symmetric. And that is one area that actually injectors have an advantage over surgeons, because it's very hard to make an implant exactly right for an asymmetric face. We may make them a little, but if you're good with your eye, you can look at that face, look them directly in the eye, and I actually get right in front of them, and I look at them, and I look for asymmetry, and I try to make them as symmetric as possible. We're not symmetric beings, and we're okay being asymmetric. However, when we minimize asymmetry, we tend to look a little better. And so I tell patients that, and so I try to achieve that. And it might be in the cheeks, in the midface, it might be on the jawline and the chin.
We are in Beverly Hills, and there is a massive celebrity influence in this area. Do you have patients coming in wanting to look like certain celebrities?
Well, they commonly come and bring me a nose that they look like with this tight jawline. And, you know, I even see 60-year-olds that show me jawlines from 25-year-olds. I mean, come on, you know, you don't have that kind of skin. However, and I tell them, you know, I'm probably not going to get that, but I can use that as a template to try and get the angles the same. And so, yes, the influence is here. But I think now with social media, it's not just here in Beverly Hills. It's everywhere. I mean, if you lived in Kansas, in the middle of the country, these people are looking at social media. They have access to it. It's very different. It used to be that here you could just walk around and see it. Now you don't have to do that anymore at all. You can see what you want. And I mean, you can look up snatched jawline and see I want that jawline. You know, and it's my job to tell them what they can and can't have, you know, the amount that I can do that, all the above.
I still think there's so much of a disconnect between what is realistic and what is plastic surgery. You know, I think a lot of people still believe that these non-surgical treatments can get them the result that someone with 35 years experience is, you know, performing a surgical procedure, and that's just not true.
Right. Well, I think there are two things that make aesthetic patients difficult, and we all suffer with them. One is what they expect, what they really expect out of this. And we don't always know what they expect. You know, people, when I give a lot of psychology talks, and we always say, you know, you've got to make the patient's expectations correct. This is what I would tell you as I look into the camera. Patients' expectations are what they are. You have to decide if you can meet them or not. They're not changing their expectations because you just say, we can't get that. They have those expectations. So that's a difficult kind of patient. And then the other kind of patient that is difficult for me, and this are people that are just generally unhappy.
Sure.
And there are a lot of people in the world that are unhappy with their lot in life, with whatever they are. And it isn't necessarily poor people that are unhappy. I mean, you can have very little and be very happy, and you can have a lot and be unhappy. And those people, it is very tough to satisfy them. And then the last person, I said two categories. So the person with unrealistic expectations, and then unhappy people. And then this would be 1B of the unrealistic expectations. I think there are a lot of people with some levels of what we would call body dysmorphic
There
problems,
is definitely.
where they're just looking at these pictures and that's all they think about.
Sure.
You know, I have somebody in my practice in Sacramento, and all she thinks about it are making her eyes like this. And I'm like, I want to say to her, why? And she keeps showing me pictures of that. And it's very hard in those people that have this dysmorphic thing. They're not right. And that's why doing gender affirming surgery is so nice, because it's some form of dysmorphism.
Yes.
But you can change them a lot. You can talk to them and the change is nice and big and they want that.
And it's so satisfying.
It's so satisfying.
Yes.
So they tend to be very satisfied patients of mine because we have a lot of talks beforehand and we get to what the expectation can and ought to be. We get to what we're going to be able to do and not do. And they tend to be satisfied. But these people that just feel, some of the time they're finishing a surgery and they're thinking about their next surgery.
Yes.
And social media has really increased the numbers of people that have body dysmorphic disorder.
Absolutely.
It's just out there.
Well, the photos that they're putting, and I'm guilty as charged of using filters, but it's not reality.
Yeah.
So
exactly.
the starting point is not the starting point because it's not real.
Right. Yeah. They what they want is something that, they see this nobody ever brings me a person who had a big bump on their nose. They're very average looking and they don't bring me that patient.
No.
They bring me the gorgeous patient that had a big bump on their nose and I made them look stunning. And the change in average looking people is phenomenal.
Yeah, absolutely.
But people associate with attractive people. That's why, the job market shows that they get a little better jobs. They get paid a little more. They get all the above. It's unfortunate in our society, but that's the way it is. And people know this and they stare at their phone all day long.
And it also, the smallest things can increase confidence. And I think that's why these treatments are so popular.
Yeah. And in happy people, that's what's great about what I do and what you do. Because making small changes, they're like, this is fabulous. But in unhappy people, they're just like, it wasn't enough. It didn't work for me. It probably worked. It did what it was going to do, but you're just not accepting of what,
I think it's also very telling if they've been to many other providers and they're running those providers down and explaining that they didn't get the outcome that they desired.
Right.
That's a big red flag for me in practice, for sure.
I couldn't agree more. It's the people that go for multiple consults, they're just not super happy people. And,
you are so passionate, again, I've said, about education. Where are you off to next to lecture?
Well, this weekend, I'm speaking, and I just have to think, I'm speaking in Dallas.
Yes.
Doing a cadaver course there at Aesthetic Next. And then the weekend after, I fly to Istanbul for the European Academy of Facial Plastic Surgery. I'll be there for a week, taking a couple of days there. And then I'm back for a couple of weeks and then go to Croatia. I haven't been traveling as much because I've felt like I've gone to enough countries in my life. And I've always enjoyed when I've come to Australia. You've got to get me to Australia.
Absolutely. Yeah. So you're 35 years in. How does someone like you get better?
Well, I'm always thinking about the way I can change a procedure a little bit. As we see my little dog that's here. The way I can change a procedure a little bit to make it a little better. I'm modifying procedures. I'm always trying to perfect what I do my injection a little better, and really what that takes is a critical eye looking at what you do and really looking at your results. I'm never quite satisfied with what I do. There was a famous guy in the United States who's been dead several years, but he was one of the fathers of rhinoplasty. His name was Jack Anderson. And I've learned from a lot of his teaching. And somebody talked to him at the end of his career and they said, you've done 10,000 rhinoplasties. How many of those you've really been satisfied with? And he said 2. I don't know that it's quite that, but I
love these stories.
Yeah, but if you're self-critical, there are a lot of improvements that we make in people, but they can always be better. And I'm thinking, how can I, one of my friends told me about a little thing that he does with a facelift, just a little modification of the flap. And I'm using that now. The facelifts aren't any better, but the incisions look a little better. And so I'm always modifying little things to try and say, how did this neck turn out after I did it? How did this turn out after I did it to make it the best? That's what I'm always saying to myself. I also try and do some other things that keep me interested outside. I own a winery, and I grow and make a lot of wine, grow grapes and make wine. And then I've recently started to have a marijuana farm that I'm part owner in Washington State. So I like doing different things, and I'll never, I'm not tired of doing what I do for quite a while. I don't see myself being tired of that for quite a while. Yeah.
I've been mentoring a lot of younger nurses, and I've found that teaching has made me a better clinician.
Absolutely.
And it's been so great, and it's brought me so much satisfaction. Do you find that?
Yeah, teaching makes you organize your thoughts.
Yes.
It makes you ask yourself, why do I do what I do? Not just do it, but why do I do it? And in doing that, you might change it a little bit. It makes you the best you can be. So,
on that note, thank you for being on the FACE podcast, Dr. Jonathan Sykes.
Thank you very much.